We know that clinical trials can be overwhelming. They can be confusing. It's sometimes hard to understand what's going on. But that's why we at LLS have created a dedicated service to answer your questions and help guide you through the process to be an extension of your healthcare team. To learn more, we'll now hear from Tiffany, who's the manager of the community programming at the Patient Story, as she interviews one of LLS's nurse navigators, Melanie Fife.
Welcome, everyone, and thank you for joining us for our Living Strong with MPN program. My name is Tiffany. I manage community programming at the Patient Story, where we are committed to bringing human answers to your cancer questions, which is why we are grateful for our partners like the Leukemia and Lymphoma Society, who offer a wide range of support and resources. Today, we're going to discuss a specific service that helps bring innovative and novel therapies to blood cancer patients, the Clinical Trial Support Center. I have the pleasure of speaking with LLS Clinical Trial Nurse Navigator, Melanie Fife, who will provide more in-depth information about this great resource. Welcome, Melanie. Thank you so much for joining us for our program, Living Strong with MPN. And first of all, how are you doing?
I'm doing great. I'm glad to be here today.
Thank you so much. So let's just kind of kick it off. This is such a great resource, but can you really explain to me and the audience exactly what clinical trial nurse navigation is, especially given the complexities in the healthcare system dealing with clinical trials?
Of course, I'd be happy to. Clinical trial nurse navigation is technically a service that helps patients and families navigate the clinical trial process. So patients and families work with trained registered nurses who act as a guide to kind of help them understand clinical trials, search for clinical trials, and also help overcome any barriers to participating in a potential clinical trial. And these navigators also help provide one-on-one support that's personalized, and they can serve as a resource for questions and education during the patient cancer's journey.
So let me ask you this follow-up question. So for the clinical trial nurse navigators, are they all dedicated registered nurses, or are there a variety in terms of education credentials?
I think there's a variety. Everybody's a registered nurse, but there's a variety of credentials that we all have. Some people have their masters. There's certain ones that have been nurse practitioners in the past or clinical nurse specialists.
Specific to LLS, what can you tell me about the Clinical Trial Support Center?
So the LLS, or Leukemia and Lymphoma Society Clinical Trial Support Center, is committed to providing resources to help patients actually access clinical trials. So we have a free personalized service that includes several things. So it includes personalized clinical trial matching. So we work one-on-one with patients to help identify trials that match their specific diagnosis, stage of disease, and many other factors. We also provide education about clinical trials, including risks and benefits, and can answer any questions patients and families have about that. We help patients identify potential treatment options, including those clinical trials, obviously, and connect them with clinical trial site staff. And we can help overcome those barriers I mentioned with a clinical trial. We also provide ongoing support, including identifying and connecting them with LLS resources, such as our Information Resource Center, financial assistance programs. And ultimately, we're here to just build that web of support and make sure we're supporting patients through their cancer journey, providing guidance and just answering questions as needed.
There are so many, the internet is just full of information that can be overwhelming, especially for a patient that may be considering a clinical trial. So, especially for even clinical trial support resources. So what sets the LLS apart from other resources out there that offer clinical trial support?
Well, Tiffany, I'm really glad you asked this question because I can't wait to tell you how awesome we are. So first of all, we are a team of 12 highly trained nurse navigators. And as I mentioned, with different varying degrees, and we're with expertise in both pediatric and adult blood cancer. So we are a completely free service where any patient, family, or even healthcare professional can reach out to us. We're here to really be an extension of the patient's healthcare team, really, and to ultimately educate, support, and empower patients to be active participants in their care. So it's this unique relationship between the patient, family, and our nurse navigators that really sets us apart. and enables us to provide personalized, like ongoing support. Instead of just simply providing patients with a long list of clinical trials, the clinical trial nurse navigators at LLS take the time to really get to know who the patient is, what their goals of care are, and really meet them where they're at. We provide a pared down clinical trial report that takes into consideration the unique patient characteristics, such as their past medical history, previous treatment responses, ability to travel, types of insurance, any of those other life circumstances that can really impact their ability to participate in a clinical trial. And we also do an enormous amount of outreach on the patient's behalf, including talking to our pharmaceutical partners, to clinical trial site staff, including principal investigators and coordinators, to provide patients and their families with the most up-to-date information so they can make those informed decisions.
Thank you so much for saying that. So that was a breadth of information, but I heard some words that really resonate with me personally as a former caregiver, which is being an active participant in your care, and that you all are able to help people achieve that goal, because a lot of people can't do that. And also personalized care. What you all do in terms of getting to know the patient and their past medical history, I think that's just such an amazing service. And so I want the audience to be able to take advantage of that. So how can they get in contact with the LLS Clinical Trial Support Center?
Good question. Good question. So patients and even healthcare providers can contact us at the LLS Clinical Trial Support Center through either our Information Resource Center by calling 1-800-955-4572, or by visiting our website at www.lls.org. And they can also email us directly with any questions at ctsc@lls.org.
Well, Melanie, in this short amount of time, you have given us so much information. Again, I want to thank you so much for taking the time to participate in our Living Strong with MPN program. And thank you so much. Any closing remarks?
Just thank you so much to you and the Patient Story for having us. And I hope everybody knows we're here to help.
Thank you so much. Wow, what a short but impactful conversation. Melanie's insights and expertise have been invaluable. I'm sure you heard her email notifications going off during our conversation. I'm going to wager that those are patients just like you requesting clinical trial support. I look forward to seeing LLS continue impact on the lives of blood cancer patients. If you are interested in participating in a clinical trial, please take advantage of this service. And finally, on behalf of the Patient Story, I want to give a special thank you to our audience for attending this evening's program in St. Louis, and to all of you tuning in virtually. Enjoy the rest of the event.
Thanks to both Tiffany and Melanie for highlighting that awesome service. The Leukemia and Lymphoma Society's Clinical Trial Support Center is an amazing resource for patients and their families navigating clinical trials. The dedicated team of nurse navigators provides personalized service, helps match patients with suitable trials, and assist with the enrollment process. If you or someone you know is considering a clinical trial, please don't hesitate to reach out to the LLS Clinical Trial Support Center. Just as a quick note to our friends who are watching online, there seems to be a little bit of an audio issue with it appearing or coming out low. Been recommended to try to put headphones or connect headphones to your computer to hear a little bit better. Taking a step back, looking at some of the active clinical trials that are going on and what that means for patients, and just a little bit of an update. I'm going to stumble again through these drug names, but I hope Dr. O will correct me. Tell me about the phase 3 MANIFEST-2 study of pelabresib. Yeah, see, I knew it, yeah.
Yeah, so thank you, Josh. So all of these drugs, there are probably 7 different ways you can pronounce them. The way that I understand it to pronounce that one is pelabresib, or some people say pelabresib.
That sounds better than what I said.
But don't worry about that. The MANIFEST-2 study, I know some of you are familiar with it, is a phase 3 study for patients with myelofibrosis, in which patients were randomized into 2 groups, which is the way these phase 3 studies usually are done. So you have 2 groups. One group receives ruxolitinib as the most common treatment for patients with myelofibrosis, and the other group receives ruxolitinib plus pelabresib. And because of the nature of the way these studies need to be done, the group that receives ruxolitinib alone also receives a placebo, so sort of a sugar pill, that instead of the pelabresib, and nobody knows initially which of those groups the patient is put into. That's by design, so that we can determine if the pelabresib is actually adding something beneficial. So it's a very common, typical phase 3 study design. Let me back up and say phase 3 is the most sort of advanced development within clinical trials that typically would be before FDA approval. So you have phase 1, which is the first phase, where that's usually a smaller study. The drug is administered, the study drug is administered often at very varying doses, and the primary objective is to determine, is this actually just a safe and tolerable drug? And of course, that's critical to establish that, and then you move on to phase 2 and then to phase 3 to learn if the drug is effective, okay? So phase 3, MANIFEST-2, pelabresib, the question is, adding that to ruxolitinib, does it provide additional benefit? That study that we participated in, and we have been participating in, at the last year's ASH meeting, the American Society of Hematology, some of you know that there's a big national or international meeting, the ASH meeting every December. And at that meeting last December, the initial results from that MANIFEST-2 study were reported. And the summary is that the patients who received the two drugs together, clearly there was superior benefit in terms of spleen reduction. So we know, as we've talked about, that ruxolitinib can reduce the size of the spleen. Well, the two drugs together shrunk the spleen even more. There was no question that the two together were more effective in that regard. And that is really, for most studies in the myelofibrosis field, is what we call the primary endpoint, is the most important metric or readout as to whether a particular treatment is effective. It's something that we can, as some of you know, you can image with various modalities in the setting of clinical trials, typically either MRI or CT scan. You can get actually the exact volume of the spleen, and then you can calculate how much change there's been over time with that particular treatment. So with that study, clearly the combination treatment was superior. The secondary or key secondary endpoint is about symptoms. And again, we know the ruxolitinib is helpful for symptoms, so the question was, adding pelabresib, does it provide additional benefit for symptoms? And there, the answer was kind of plus minus. It wasn't clear that the combination treatment was definitely better. There were some aspects that suggested a little bit better, but it wasn't a slam dunk. And that study is continuing to progress, but that is the initial readout from that study. And further data is required to understand if this really makes sense as an available treatment option and as to whether that will lead to FDA approval.
I want to take just a quick step back because we have a lot of different patients in the rooms and a lot of them online, and we don't necessarily know where they are in their journey, especially their treatment journey, and if they've been introduced to clinical trials. And one of my goals in the work that I do is to break down the myths of clinical trials. And you mentioned a word that sometimes strike fear into patients. You said the word placebo. Can you take a step back and just talk about MPN clinical trials, what that means for a patient and how standard of care will always be a part of it?
Absolutely. So I think there's a couple of different perspectives on this kind of thing. So on the one hand, if you look at it from a patient perspective and think about a study in which participating in a study, you might get placebo, you're not getting the active treatment, you might question, why would I want to do that? Why would I take that chance of committing to this extra time involvement, extra monitoring, hassle of that kind of thing is, when I don't even know what I'm getting, right? So that is a real and legitimate concern, and it's a question and a reason why many choose not to participate in clinical trials. That's perfectly understandable and appropriate. But to understand if a new treatment is effective, that is really necessary. because otherwise you really have no indication. The earlier phases of the study, there's not typically a placebo. Every patient gets a study treatment. That's attractive from a certain standpoint because you're getting the study treatment, you're getting the active treatment. That's great, and is, again, definitely a reason why some might favor participating in a study at that point. But the placebo is necessary, or some comparison is necessary. But as Josh was saying, typically, as in the MANIFEST-2 study, patients are at a minimum getting the standard of care. So they're getting ruxolitinib. Now, there's, of course, 4 JAK inhibitors that are now available, but particularly at the time that study started, ruxolitinib was the predominant JAK inhibitor that was used. So you could say, well, every patient gets a good treatment to begin with. You're getting that, and then plus or minus the study treatment. So that's how I would phrase it.
Yeah, absolutely. Thank you so much. I just want to make sure that we're clarifying that for everybody who's with us tonight. I want to jump back into some of these other clinical trials. Can you talk about a status of the BCL2 inhibitors for MF?
Do you want me to take this one?
I can start, but I would say you could add to it in case I lie to everybody here. So with the BCL2 inhibitor, so as Dr. O mentioned, we have this annual meeting, the ASH meeting, where a lot of, data is presented regarding the results of some of these clinical trials. And so navitoclax was a medication that is a BCL2 inhibitor, so it works in a way basically where, the study that they presented at last year's ASH was also a phase 3 study, very similar in design to the study that we just talked about with pelabresib, where the question was, if you add this other medication on, to standard of care, ruxolitinib, do you get a better response, in regards to spleen improvement or symptom improvement? And I think similar to the pelabresib study, with that drug, there was a bigger spleen response with the combination versus ruxolitinib alone. They didn't see a big difference in the symptoms either. And then, I would say as far as the other aspect of things, which is the safety of adding another medication on top of, an existing medication, whether or not some of the side effects could be worse. And so the combination did have lower blood counts. So I would say that is a concern in regards to whether or not the combination kind of is the best strategy versus doing that ruxolitinib by itself. So I think as far as FDA approval goes, because that's really the next step after, they do these big trials and they have, the results, is whether or not, from a safety standpoint and what the drug does, whether the FDA thinks that it would be something that they would approve for everybody to use. So I haven't gotten any updates regarding FDA approval for that medication, so I'm not sure, kind of what the result of that will be.
Thank you. Either one, the Century study for I'm not even going to try, please.
Selinexor.
Selinexor, thank you.
Yeah, so I can comment on that. So selinexor is a treatment that is currently FDA approved for some subset of patients with multiple myeloma, so it's somewhat different disease, but is being explored for patients with myelofibrosis. It is a little bit different than the way it's approved for patients with myeloma, in that lower doses are being used. There has been some concern with side effects with that drug in the myeloma setting. With the lower dose that's being used in the myelofibrosis studies, perhaps that's less of a concern. There is this ongoing or relatively newly started phase 3 study now with selinexor in myelofibrosis based on earlier phase studies showing promising activities. So that is of interest for sure to us and to the field as a new sort of strategy, and that is in combination with ruxolitinib, very analogous to the studies we've been discussing with pelabresib and navitoclax. So we'll see how that progresses. We're not currently as a site participating in that study, but we're certainly interested to see how that progresses.
And the last one, developments regarding KRT-232.
Yeah, I think because I'm not, I would say I'm not as familiar with,
Yeah.
kind of.
Sure. So KRT-232, also known as navtemadlin. So
I'm glad they didn't write that one down.
yeah. So that drug is also being explored in myelofibrosis and has gone through various phases of studies and is now in a phase 3 study as well. There is some data that will be presented at ASH from some of the earlier phase studies with navtemadlin, suggesting that it may have some ability to not just improve spleen size or symptoms, but improve some other underlying aspects of the disease. So that is appealing from that standpoint. I think, it is, again, of interest. We'll see how the phase 3 study progresses. But I think, more broadly speaking, and I hope, for those of you that are more focused on PV and ET, it's not, this is not all about myelofibrosis, but this is certainly just another example where there are a number of novel agents that are in various phases of development that, beyond the currently approved 4 JAK inhibitors, we have, all of these other treatments, and they're very different from JAK inhibitors, which are progressing through different phases of these clinical trials.
Now we get to transition to my favorite part. What does the future look like? What are you excited about? And the question becomes, we see our clinical trials now, we see the research going on, and you can theoretically look a year down the road and kind of see what's coming towards us. Where do you see MPN treatments in 5 to 10 years? What are the key areas of focus that researchers are looking at now for those 5 to 10 years?
So I'll just start off by saying, I know Dr. Zhou mentioned this earlier. So with the CALR mutation, so patients with ET and myelofibrosis who are positive for this CALR mutation, we think in some ways that the CALR mutation is a little more favorable in terms of risk of blood clots, in terms of sort of lower risk disease overall. But that said, again, we know that these diseases can cause problems, whether it's in the short term or the long term. And we would love to have more effective therapies for any forms of these diseases. So with the CALR mutation, there are several different strategies which are now going into early phase development, which are very specific for this CALR mutation. So more of that personalized medicine approach. Dr. Zhou mentioned this CALR antibody. So we are participating in that study. We just opened it. So patients with ET and myelofibrosis who have the CALR mutation are eligible for that study if they meet the other specific eligibility criteria. It is a good example of a setting where you might say, well, if you have a patient with ET or MF who has the CALR mutation and maybe they're doing okay overall, you might initially say, why would they want to pursue a clinical trial and receive an experimental therapy? And again, that's perfectly reasonable to say, full stop, I'm not interested. But this maybe is a treatment that might be capable of having a profound effect on the disease and be more effective than the other available therapies that we have right now. And so for that reason, it's, I think, appealing for certain types of patients in certain situations. So we are participating in that study, and there are other specific personalized treatments for patients with CALR mutations, which are in early phase development as well. And so I think it's a very exciting time in that sense for those types of approaches.
Yeah, excellent, thank you. Dr. Zhou, two-phase question here. We've mentioned the term personalized medicine a couple times. Can you just give us a high-level overview of what that is? And then how impactful is the role of personalized medicine in MPN treatment? Specifically, how do you see genetic testing being used to tailor those treatment approaches?
So I think, yeah, we've definitely touched on this a little bit. I think right now with the current therapies, it is more, I would say, something that is less personalized in the sense that it's effective for everybody. We don't necessarily use somebody's mutational status to decide, like, for example, which JAK inhibitor they could use. And so I think that as we have more treatments available, I do foresee that hopefully will be the future, is that, depending on what mutation somebody has, we may have therapies that are more specifically targeted for those specific mutations. But I think that that's still a work in progress right now. Yeah.
Yeah, excellent. I mean, it's a work in progress across the hematology oncology sphere, but thank you. Question to both of you. MPN, along with a lot of other blood cancers, are often seen as a disease of older adults. However, across the board, we're seeing growing numbers of younger individuals being diagnosed. One, can you talk about what that means? What is a younger individual to you? And two, how might this shift in demographics impact treatment approaches, possibly even clinical trial design and research? And are there unique challenges or even opportunities associated with treating a younger MPN patient?
Yeah, so you want to go first?
Sure, you can go first.
So I think this is an important topic. So yes, we've historically thought of, and the statistics are that the majority of patients are diagnosed at older age. However you want to define that, I'm still in the young category, I'd like to say. But the reality is that increasingly we are diagnosing patients at younger age, and part of that, of course, is increasing recognition. Some patients maybe, we may have diagnosed at a certain age, but maybe they had the disease years or decades prior. There is a lot of research that's come out in recent years where we have learned that some individuals, maybe we found the JAK2 mutation, let's just say, for example, at age 60, but they actually had it when they were age 20, or maybe even younger. It's kind of a crazy concept that we actually now know may be the case. So these things may be sort of brewing or sort of latent, hanging out for a number of years before they're diagnosed. So we're realizing with additional research, with more studies, a better understanding of that concept. When we think about individual patients who are diagnosed at younger age, on the one hand, we say, we know, particularly let's say for PV and ET, that patients can live decades with these diseases and their disease may remain stable for that entire span, 20, 30, 40 plus years. And so you have a long life to live. You're going to live with this disease, and that may be perfectly fine. But we also have to consider that living with these diseases for that period of time, however long that may be, that some type of complication could occur at any point in that time, and that over that longer period of time, there is that looming possibility that the disease may ultimately progress. And so we have to think of it in terms of being proactive, thinking ahead, being prepared for those possibilities. And it reinforces that though we want to make sure to reassure patients about the favorable outlook for these diseases overall, that we are continually striving for, can we more effectively treat the diseases? Can we maybe treat them earlier with safe therapies that will prevent those long-term complications from ever occurring?
Excellent, thank you. Dr. Zhou, anything to add?
I mean, that was great. And I think as far as, the question about maybe some unique challenges for managing, some of our younger patients, I think something that I am becoming more cognizant of is, kind of the fertility aspect and just things that, I would say may not necessarily be a consideration, for older patients, however you define that. And so, we certainly do see some younger patients in my practice in Dr. O's clinic, and that is something, I'll be honest, I had to, kind of make myself aware of is, okay, these are some additional unique challenges. So making sure that they see one of our fertility specialists, for example, because some of the medications that we prescribe, may affect that. And, managing our patients through pregnancy, for example, things like that, which are unique for younger patients dealing with this disease, balancing, that safety and yeah.
Yeah, that's an incredible insight that somebody might not think about. I really appreciate the fertility aspect of it. Thank you both for your insights. Wonderful conversation. We're going to have some time now for questions from the audience, both virtually and here in the room. We're going to try and balance those out as we go around. Remember that Doctors O and Zhou cannot offer personalized medical advice. We do encourage general questions about symptoms, diagnosis, treatment options, clinical trials. So as we open the floor, we'll work in the room. I have an online question first. What causes patients to be anemic and need transfusions?
You want to take it?
Sure. Sure, I can take this. So I would say it really depends, but I think specifically in regards to if it is, from the disease, I would say it's complicated in regards to, of what goes into, kind of development of the anemia, but it is a common complication, in myelofibrosis. And I think that, the mechanisms behind, what leads to that and what leads to the worsening of the anemia is, I would say there's many factors that go into that.
Are there ramifications for being transfusion dependent?
So, in regards to like prognosis, so transfusion dependence and anemia definitely are considered to be worse prognostic factors. And so those are important factors that are incorporated, into these risk stratification systems that we have for our MF patients. Again, in regards to trying to estimate their risk for progression to a more aggressive type of blood cancer like acute leukemia or survival. Yeah,
excellent. I did see a hand somewhere in the room. Oh, there we go. Just give us a second while we get the mic back there. Sir?
Yes, I was told by Dr. O that I acquired this CALR. It's not a hereditary thing. Is that correct, Dr. O?
Yeah, so just to repeat the question for everyone in the room as well as the online participants. So the question was, for someone who tests positive for this CALR mutation, are you born with it or do you acquire it sometime in your lifetime? And my response really applies to CALR as well as JAK2 and also to MPL. These mutations are generally not something we think of as individuals are born with. And let me just try to be as precise about this as possible because it can be very confusing. So when we think of mutations as in some cases being born with them, we think of diseases or disorders where mutations might be passed down from parent to child. Okay, there's many examples of disorders where that is the case, where a parent has the mutation, they transmit that to the child, and that's a sort of a defined genetic disease. These are not those kinds of diseases, or these are not these kinds of mutations. The JAK2, CALR, and MPL mutations, you're not born with them, and well, more specifically, they're not passed down from parent to child, okay? So we think that at some point, a blood cell acquires this mutation. Over time, those cells expand that carry that mutation, and then at some point, the disease becomes apparent. I'm choosing my words a little carefully, in part because of some of the research I mentioned a few minutes ago that has come out in recent years, where we have begun to understand that the exact timing of the mutation acquisition may be years in advance of the disease becoming apparent, but that doesn't change the fact that we don't think of this, it's not something where parent has a mutation and transmits it to a child. So the practical question that commonly arises, of course, is if a person is diagnosed with one of these diseases and is found to be positive for CALR or JAK2 or MPL, the question is, do I need to worry about my kids? Do I need to get them tested for these mutations? Is that possible that they could have it because I have it? The answer is, no, they're not gonna get it from you. That's not how it works for these types of mutations. The more complicated answer, I'll just kind of take a minute to address this, is we are aware that there is a slightly higher risk of family members developing a similar disorder. So what we call first-degree relatives, so siblings, children. We see this in some families where multiple family members will have one of these diseases. It may be that one family member has PV and another family member has ET. We see that on occasion. It's not super common, but we know there is a slightly increased risk. That risk is on the order of 2 to 4-fold higher. In general, we think of these diseases as approximately 1 to 2 out of 100,000 in terms of incidence. So when we multiply that, I'm sorry to get into the mathematics here, but if you multiply 1 out of 100,000 times 4, that's 4 out of 100,000. That's still pretty uncommon. So for that reason, we don't recommend routine screening of family members. But it is true that there is a slightly increased risk. and that there are families where multiple family members are affected. It's not because the JAK2 mutation or CALR mutation is passed down from parent to child. It's because there's something else going on, probably some other genetic aspect that results in some shared increased risk amongst family members. But strictly speaking, the JAK2 CALR mutation, they're not passed down. You weren't born with that in that sense. And apologies for the really long response to that question.
No, I think that's a question that comes up in every blood cancer education program that I do is, how does this affect my children, grandchildren? So thank you for going down that road. Yes, ma'am, right there. We'll get you a microphone, just 1 second.
I can yell pretty loudly.
You don't have to.
Thank you. Dr. O, do we think that any of these are not environmental per se, but influenced by environment?
So that is a great question. Let me respond in a couple of ways. So on the one hand, we do think, of course, of these diseases as being fundamentally driven by these mutations, JAK2, CALR, and MPL being the most common, and then a blood cell acquires these mutations as we just talked about. But as to the role of the environment, and the environment can refer to many things, of course, there is increasing, at least, evidence to suggest there is some potential impact, and some examples of that. So some of the research that my group has been doing in the laboratory, and many others in the field as well, has focused on the role of inflammation. And inflammation is a very broad term, of course. Some of you are quite familiar with different types of inflammatory disorders, autoimmune diseases, and things like that. But as a concept, what I'm getting at is that we think that inflammation can have an impact on how these diseases develop. Doesn't necessarily cause these diseases, but if there's some abnormal inflammation, it may have some bearing on the disease course and the disease progression. That is a very tricky concept, and how that relates to individual patients, may vary, and I think it's fair to say we don't fully understand. But other aspects of the environment, so when we think about inflammation in that sense too, you could think about maybe infections. So when this concept of these mutations may be initially being acquired years or decades prior to the development of the disease, we know that in some cases the mutation may be at a low level at one point, and then 10 years later it may still be at a very low level. In other individuals it becomes much higher. Why is that the case? Why is it different in individual patients? Probably a lot of reasons, but one may be environmental aspects, inflammation, infection. Maybe a severe viral infection could precipitate a change in that regard. This is a lot of speculation and theory, so to speak, as opposed to hard evidence, but I think we're beginning to better appreciate that could be a contributing factor.
Excellent, thank you. And bouncing back to our online audience, question from Gail. Dr. Zhou, why don't you take this? What treatments can you suggest that might delay progression, especially for ET or pre-MF? We're thinking about patients with few symptoms, but maybe high platelets.
So, I think in regards to progression, I'm assuming they mean, maybe progression to myelofibrosis or acute leukemia. And, I would say right now it's not clear whether or not, there really is a therapy that does decrease somebody's risk for progression to myelofibrosis, or acute leukemia. Dr. O mentioned there's a lot of interest, in interferons in PV and ET, and kind of the disease-modifying properties of that drug. But as far as whether or not, so not to get too much into it, but I think one of the aspects of that treatment is they mentioned that it decreases, the amount of mutation that you can detect in the blood. So the JAK2 mutation, for example, the amount of it might go down over time and maybe sometimes won't even be detectable, with that treatment. But whether or not that's an adequate surrogate or replacement for survival, like actual data to show that, okay, if you take this medicine, you will live longer, or you will, people who take this will have less risk for myelofibrosis. I would say that's data that we don't really have, because the good thing is, patients with ET do so well. So if you do a clinical trial looking at those, what we call endpoints, you'd be following patients for a very, very long time. And so that's why we don't necessarily have that information. And so that's my long-winded answer in regards to, it's complicated, but it's unclear. And so right now, there's not necessarily any treatment that we recommend where we say, yes, you should take this because it will decrease your risk for progression to myelofibrosis or acute leukemia. Yeah.
Thank you. Anybody in the room? Oh, just 1 second while we get our microphone over there.
Any recommendations, Josh, for lists of email lists where patients can converse and talk about what they're experiencing?
Yeah, that's a great question. So not necessarily an email list, but what I would recommend is LLS's patient community. It is our social media site or patient forum. And on that site, we have a number of different forums regarding all different blood cancer diagnoses. So MPNs is covered. There are even 3 subcategories for the major MPN subcategories, as well as treatment, different psychosocial topics that are also covered on there, as well as being able to connect with patients in other populations around the country that you might relate to, from LGBTQIA to rural patients, all on the LLS community. The best part about it is that it is monitored every day by one of our information specialists, so one of our nurses or social workers. So if something is posted in error by a patient or might need some clarification, they're there to add it and provide reliable sources. And it's a good place to go to, one, connect with patients, know that it's being monitored for truthful and accurate information, and that way you're not always constantly asking Dr. Google about what's going on with you, because we know Dr. Google sometimes lies. So LLS patient community is a great place to start.
Josh, if it's okay, I would like to comment
please.
further. So some of you are aware there are lots of different sources of information online. So in addition to the great resources Josh mentioned, there are various websites. There's MPN Research Foundation, has lots of great information. There is MPN Advocacy. Some of you are probably familiar with that. If you just use Google, not Dr. Google, you'll find MPN Advocacy. So there are email listservs and stuff like that, newsletters that you can join to receive those updates. I just want to add as well that some of you also, I think, are familiar. There are various Facebook groups for patients with MPNs. I think some find that extremely helpful, and some of you that are here in person, you're getting to meet others with these diseases for the first time, and that's meaningful. Online support groups can provide that as well, and again, be really helpful for individual patients to cope with these diseases and diagnoses. In certain circumstances, that can lead to more distress. So I always caution patients to, you have to make that determination as to whether these kinds of things are helpful. And again, in certain circumstances, it just sort of amplifies the concern and the stress and so on and so forth. So just think about that when you explore these different options.
Yeah, thank you. And thank you for asking me a question. I wasn't expecting that. Yes, sir, right there.
Hold on 1 second.
Oh, I'm sorry. Yep.
Is stem cell transplant always a treatment of last resort, or do you ever recommend it, for instance, for a patient with myelofibrosis before it goes into leukemia or something else?
It's a great question. I'll give you my own perspective, and Dr. Zhou may like to offer her thoughts as well. So, on the one hand, I would say that as a non-transplant specialist, in some ways I look at it as We'd like to optimize medical therapies so that we can avoid the potential risks of transplant because they are substantial. On the other hand, if I made myself a transplant specialist, what I would probably say is, this is currently the one treatment that has the prospect of long-term disease-free remission, and maybe even we can use that word cure in some cases. And in the best cases, patients do really well, and they have minimal complications, and it's a great outcome. Okay, so that's the other sort of side of the coin. And so to go further along those lines, some might say the goal is to transplant everybody, to make that approach safer and more effective, and we should be focusing our efforts on that and make it available to everybody. That's that's the most extreme perspective along those lines. But I think there's a middle ground, and it's really patient specific. So certainly not last resort, but at the current time, we choose carefully patients we think are in need of transplant and who we think are well enough to withstand the potential risks that go along with that.
I'd like to ask a little bit of an overarching question. It's something that is near and dear to my heart about equitable access. And a lot of our patients who might be watching online might live in a more rural area or further away from a cancer center. Both of you work at one of our premier comprehensive cancer centers. Dr. O, you and I have talked about how patients drive for hours to see you, and I'm sure Dr. Zhou is the same way. But that's not always a possibility for our patients, especially those underserved. They might not ever hear about a clinical trial. They're probably getting treatment in their local community oncology office. What are some ways that we as a society, as a world, or what are you doing to address maybe some of these obstacles that patients might face?
Sure. I think, and I'll be honest with you, I don't have, I would say a great solution to that challenge. I think that as far as the educational portion of things, because I think we recognize, for our community colleagues where they may be seeing many different types of cancers. And because MPNs are a rare disease, this may not be a part of their clinical practice, compared to lung cancer or breast cancer or many of these different diseases that they treat. And so, as far as kind of staying up to date with the latest, therapies and things, I definitely, I would say for myself and Dr. O, we've participated in, kind of education that's geared towards our colleagues as well. And certainly we've always been very, amenable to providing advice. If a patient is not able to come see us, sometimes their provider may reach out and ask, hey, can I just get some information on that? And so, I would say sometimes we can provide some information to local oncologists if, the patient that they're seeing is not able to travel to St. Louis or an academic center. But I would say as far as, kind of some of these therapies, so the clinical trials themselves or, transplant, for example, where they are not offered, at some of some other more community-based practices, I do think logistically that's going to be a challenge, and in regards to whether or not, because I think Siteman, does offer, for example, like housing sometimes for our patients if they have to stay overnight, if they have to travel far. But certainly, I think that resource, providing resources to help support patients who want to be able to, access these treatments, but, may be constrained in various ways. But I would say that's definitely a challenge sometimes.
No, thank you for taking a shot at it. It's a complicated question, and none of us are going to have right answers, but it's how we approach those underserved patients and how we make access for them. I know Dr. O's office is more than willing to help. His nurses, his clinicians all reach out to patients, and I know your clinic does as well. So I'd like to turn it back to the audience.
On that subject, I'd like to tell you a quick story. I had ET for 10 years, and my provider saw a web seminar with Dr. O, and suggested him and another lady that I drive because I live in a rural area, to see Dr. O, and I don't see why anyone can't drive 2, 3, 4 hours to try to get themselves a diagnosis, because the way Dr. O was so open, and Tammy was a great help. They take your files, they analyze them, and then they call you back and they make your appointment. And the only bad part was they took about half a liter of blood out of my arm. But then within the next 2 to 4 weeks, I spoke to Dr. O 3 times on the telephone. And finally he said, well, you're pretty lucky. You got CALR mutation. I said, why is that? He says, well, of all the people that have ET, the ones with the CALR have the best longevity. And then I looked up the CALR, and it was discovered 10 years before Dr. O told me about it. So now I'm going on 13 years. So I think that it should be pushed out there to the rural people that make the sacrifice, if it's 2, 3, 4, or 5 hours, and come to see Dr. O or anyone in another city in Cleveland or Pittsburgh. They should feel that they're not getting it.
I think your story leads to a great question. For those patients who are driving 1, 2 hours, how can they optimize the time with their healthcare team for not only their care, but also their quality of life, because they might not be able to make the regularly scheduled appointments that someone who lives in town might be able to attend?
Yeah, so I can comment on that, and definitely appreciate the positive feedback. We recognize that every patient has, maybe have specific circumstances or challenges that, pose real logistical constraints, no matter how far they might be coming from, when they might be in town, and it's still, there's still specific challenges. Yeah. One thing I want to mention is we do strive for our clinical trials to ensure that there is support for travel. So again, I understand fully that for many patients, that's just not feasible, partly in some cases because of the distance, but in many cases we have mileage reimbursement, we have funds for meals, we'll have, if it's a long visit, and they're traveling from a distance, we may have support for hotel stays. So we try to make that at least as best as we can to provide those resources to help patients, make it feasible to participate in clinical trials if it's appropriate. But I think the other thing that I will say I've personally learned over time is that we try to individualize a partnership between the patient and, if it makes sense, a local physician in a way that is productive. So it can be different. It can be that in an individual circumstance, the patient sees a local provider frequently and comes to see us once a year, and that works well. We have arrangements where we alternate. They see us every 6 months, they see the other provider every 6 months, and it becomes every 3 months they see one of us. We try to support if a patient needs blood count monitoring, that can be done at a local lab that's close to their home. It doesn't matter if it's in our system as long as we can get the results. So we do our best to make that feasible. And when I say we, I mean our team. Tammy has already highlighted our clinical research team, Nicole and Karen in the back. So the members of our team really make that possible to support patients in whichever way makes sense.
Yeah, excellent. Dr. Zhou, as a follow-up, when you are first interacting with a newly diagnosed patient, what are some recommendations that you or your team might give them to maximize the time that they have in that clinic room with you to ask the right questions, retain the information, things along that line?
So I think for new visits, I do think that sometimes it can be a little bit overwhelming in regards to, because so much is new. You're getting a new diagnosis. Oftentimes I'm spewing a bunch of information, and it is very hard, I think, to process all of it, in like a 30-minute interval, let's say. And so oftentimes what I tell patients is, this is a lot of information I'm giving you right now. I understand that for most of us, and for myself included, sometimes you need to just take that information, have time to process it, and then think about, what questions you have. And you don't have to ask me all of it in that one visit, whether, because you can call us, you have my chart now, so you can message us. And so there's all these different ways to communicate with us where, again, we understand that this is all new and there's a lot of information to understand and process. And so you don't have to feel like you need to get, like everything done in that visit. If, afterwards you have questions, certainly I would say for our team and I think for Dr. O's team as well, we're accessible in regards to, okay, if you didn't have this, you didn't think of this question initially and you have it now, please message us and we're happy to answer that. And you don't have to, kind of wait until your next visit either. So that's generally kind of been my approach, in regards to, I would say helping to kind of best process and retain that information. But also, I've also had patients ask me to write things down, in kind of their little like after visit summary, and I'm also happy to do that too.
You mentioned something that I think has come about in, I would say, the last 10 years. And it's something very new to a large part of the population. You called it MyChart, different hospitals call it many different things, but it's a way for patients to get a glimpse into their health record that's kept by their doctor. A lot of times test results can pop up on there before you as the doctor has had a chance to go over that with a patient. Either one of you, how do you talk through that with your patients and say, yes, you can look at it, or wait till you hear from a member of my team? What is your advice?
So generally I do, my advice is, I would say I don't expect you to interpret your own test results, so I will, message you and explain these results, and then we can discuss it together. Yeah, but that's usually my advice is, don't try to interpret it yourself. Don't go on Dr. Google and try to get Dr. Google to interpret it. Let me provide that information. Yeah.
Just one comment along those lines. So I think it is an evolving dynamic between the provider and the patient. I've been on both sides of that equation with myself and family members. Sometimes you can see in my chart, there's a test result and it's resulted. It tells you the status that's resulted, but it won't give you the result because the doctor has to sign off on it, if it's a sensitive result for you to see, but you see that there is a result there and you want to know what it is, and maybe you might not be able to interpret it, right? So it can create a lot of stress, right? I understand that it's a case by case in terms of the dynamic and how best to handle that. But I agree that, it's the best and most productive way in general is to talk it through with the patient if it's a sort of a complicated result, to best put that into the proper context.
Thank you. And I'm glad that even a doctor looks at that and is like racing, like trying to see the results. So it makes me feel a little bit better about checking my cholesterol numbers. Anybody else in the room have a question? Yes, ma'am.
Okay, I have kind of a two-part question. I hope I word it right, that makes sense. The big question is, what are we doing about a cure? To actually cure this disease instead of just living with it. And then along with that, when you're talking about a cure, are you looking at the allele burden to kind of bring that down to zero, or are you is the allele burden irrelevant with that? And I don't know if I'm phrasing this in a way that makes sense, but hopefully, everything we've talked about talks about living with the disease and symptom management and lowering risk of blood clots for PV and ET, those things. But what about cures? What about ringing that bell? Being done. What's in the future for that?
Yeah. Well, so I can take the initial response. So I think these are great and important fundamental questions for individual patients, for the field. And I hopefully it's come across that is something very much on my mind and for everyone in the field, that on the one hand, for certain types of these diseases, we do have therapies that can keep things stable, they can help with symptoms, Many patients can live for many years or decades with stable disease, and that's great. Or, living with the disease, sure, that's great, but we want to reach a higher level. That is definitely a goal. How to achieve that is of course the question and the challenge. And just to give an example, in the myelofibrosis setting, we say, well, we have these 4 drugs that are FDA approved in various ways that can help with symptoms and other features of the disease. Why are we focusing on those things, continuing to focus on those things? And the answer is because we need better treatments that are capable of doing more. So we have to have those things at our disposal, or at least the prospect of that, to be able to really sort of go for that. And so these fields are evolving very rapidly, but increasingly we are focusing on that. To get more specific to some of the questions you raised, yes, in many ways the goal is to reduce the mutation burden to 0 or undetectable. There are sort of several layers of nuance beyond that in terms of what does that mean. That's a question that has been, if you go to a research meeting in this field, there will be hours of discussion about that question, with whether it's with respect to the interferon drugs, which in some patients have that ability to reduce that mutation allele burden. What does it mean? Can we start to use the word cure in some patients? We don't really know right now so much, but it's going to take continued effort, research, but for sure it is a goal of the field.
I think that was a great question to end on. And I know we've covered a lot of information tonight, but before we end, I want to ask one final question. It's something that I was talking about with my colleagues a couple days ago, but I'd love to hear your perspective. What would you say to your MPN patients now that you would not have been able to say to them 10 years ago?
Do you want me to go first?
You can.
Well, I guess, 10 years, so this is 2024. So 2014, if you look back in time, at that time we had 1 approved treatment, and that was ruxolitinib or Jakafi. Okay, so we have come a long way. We have 4 JAK inhibitors approved for myelofibrosis. We've had approval of ropeg interferon for polycythemia vera, and we have more to come in the coming years. I would say, so that's, those are all really big changes and positive developments in the field. I would also just say, I don't remember for sure, but I would say back then, I'd be giving the same message to all of you, which is, I'm very optimistic. And in the next 10 years, we're going to be making even more progress. So, this is a field of intense focus research-wise, both in the laboratory and in terms of clinical trials. And I fully anticipate that in the next decade, we're going to have big advancements coming. And so I'm very optimistic.
Thank you. Dr. Zhou?
I definitely share that optimism, and I definitely agree, kind of with the availability of all of these new therapies that has been within the past 10 years, and also, just again, kind of going back to what we were talking about in regards to molecular testing and incorporating, these additional mutations, into prognosis. So, thinking back 10 years ago, that wasn't necessarily those prognostic scoring systems that were incorporating kind of these different mutations that hadn't yet been developed. And so that is something also that's come about in these past 10 years. And so, yeah, I'm very excited to see what the next 10 years holds. Just in regards to what additional therapies and again, kind of more personalized medicine as we understand the disease better.